So I now invite Dr. Viviany Taqueti to present about the role of PET coronary flow reserve in the management of patients with ischemic heart disease.
Thank you very much, Dr. Dorbala. And what a pleasure it is for me to join you this evening in this joint TCT ASNIC session to speak about PET coronary flow reserve in the management of chronic ischemic heart disease patients. As was mentioned, my name is Viviany Taqueti, and I direct the Cardiac Stress Laboratory at Brigham and Women's Hospital, Harvard Medical School in Boston, in Massachusetts, USA. These are my disclosures. So as many of you recognize, the conventional approaches that we have historically used to diagnose ischemic heart disease have typically really focused on the identification of obstructive CAD, which can unfortunately lead to over-testing our patients, certainly in the US, without differentiating who is truly at risk. And not only does this not impart value, but it is also particularly concerning given the recent uptick in cardiovascular mortality trends that we've recently observed for both women and men. And even when we consider traditional risk categories like the Framingham risk or even symptom characteristics, the diagnostic yield of finding meaningful obstructive CAD using non-invasive testing can be low and has actually decreased over time. The Ischemia trial showed us a couple of unexpected findings in that ischemia with no obstructive CAD, or INOCA, is not only a real phenomenon, but in fact was found to be quite common in women and men. In ischemia, about 20% of patients who were enrolled, and remember, were required to demonstrate moderate to severe ischemia on core lab verified testing, actually did not demonstrate any obstructive CAD, even on very sensitive evaluation with non-invasive coronary CTA. Perhaps this is less surprising when we actually take a big step back and consider that obstructive CAD is really just one phenotype of ischemic heart disease, as we're learning. It's sort of the tip of the iceberg, if you will. But in fact, diffuse non-obstructive CAD and coronary microvascular dysfunction affecting the more distal coronary microcirculation may be at play. But in order to diagnose these types of diseases, we really need a toolbox with more sensitive techniques that go beyond looking at regional wall motion and even regional perfusion to quantify coronary flow reserve, as Dr. Thompson alluded to. And this is important because not all functional testing provides the same value. In fact, these data from the Pacific trial showed that PET actually had higher diagnostic accuracy as compared to typical SPECT or even coronary CTA for the detection of hemodynamically significant CAD as determined by fractional flow reserve, or FFR. PET, or positron emission tomography, has not only the advantage of improved diagnostic accuracy, as well as decreased radiation exposure through the use of very short-lived radiopharmaceuticals, but also importantly, the ability to quantify myocardial blood flow and coronary flow reserve to diagnose ischemia, even in those patients who don't have obstructive CAD. Coronary flow reserve, or CFR, measures the integrated effects of epicardial coronary artery disease, as well as diffuse atherosclerosis, which is so common in so many of our patients, and coronary microvascular dysfunction, on distal myocardial perfusion. And it refers to the ratio of myocardial blood flow quantified at peak hyperemia, such as with a vasodilator stress, over that at rest. Here you can see in this multidimensional cardiac stress PET protocol, which we obtain now routinely at our hospital, Brigham and Women's, you can see that from 2 10-minute scans, you get a wealth of information, including static perfusion pictures on the left to allow us to look at regional ischemia or fixed defects that would be suggestive of infarct. We get gated or functional information to allow us to quantify LV volumes and LV size, as well as the ejection fraction. And then importantly, we can now quantify blood flow using what you can see here from the dynamic images in list mode to quantify blood flow in mils per minute per gram of myocardial tissue. And we can integrate that and average it over the typical coronary distributions, as well as the whole left ventricle. So you can see from this example, this patient was able to augment her blood flow from rest to stress conditions such that her reserve over the global left ventricle was 2.18. Multiple observational registries now around the world have shown that the distribution of risk varies by coronary flow reserve. In fact, in that patient where she could at least double her blood flow from rest to stress conditions and had a CFR of around 2, she actually had a good prognosis. But in the patients who can't do that and their flow reserves are less than 2 and substantially less than 2, their risk of annualized cardiac mortality goes up exponentially as the flow reserve goes down. And that may reflect obstructive CAD, diffuse atherosclerosis, or microvascular dysfunction, and often actually can be a combination of the three. Impaired flow reserve, even in the absence of typical inducible ischemia, here you can see even in the patients who had completely normal regional perfusion imaging and no inducible ischemia, those who were in the lower tertiles of coronary flow reserve had a substantially increased risk of cardiac mortality. So again, this is independent of ischemia, and it can also be independent of the severity of obstructive CAD. These data are confirmatory data from Dr. Thompson's group that recently showed in over 12,000 patients who underwent rubidium PET that independent, again, of ischemia, whether they had 0% ischemia on a really sensitive, really diagnostically accurate test, right, PET, they, independently of whether they had 0 ischemia, moderate ischemia, or even severe ischemia, further stratifying by coronary flow reserve values differentiated those who were at a much higher risk of events. And furthermore, they demonstrated a survival benefit for revascularization by coronary flow reserve, such that patients who had substantially lower flow reserves actually demonstrated a benefit of getting early revascularization with a significant PFR interaction here. And we've further shown some hypotheses generating data that coronary flow reserve can also modify the effect of early revascularization, such that patients who had a low flow reserve to begin with, but subsequently underwent CABG. So again, with a low flow reserve, they would have been expected to have a substantially higher risk than those with a preserved flow reserve. Those who underwent a CABG actually did as well as those who had a high flow reserve to begin with. And it suggests that perhaps impaired flow reserve might be a marker for benefit from a more complete revascularization procedure like CABG, akin to diabetes or even syntax score. Interestingly, when severely impaired, coronary flow reserve can be even more prognostically significant in women. Here you see that the risk curve, when stratified by sex, shows that the female patients actually had worse hazard for the same impairment in flow reserve. And this is despite the fact that in these patients who had severely impaired flow reserves or less than 1.6, when you stratify by severity of angiographic stenoses, the women, not surprisingly, had a lot less obstructive disease or even non-obstructive disease, and yet they still had impaired flow reserves. So we were not able to really fix their problem, right, with revascularization, and potentially that could be why they have worse hazard. So these are all potential hypotheses to explain why it is that flow reserve, when impaired, even in the absence of ischemia or obstructive disease, can make an important impact on survival. This illustrates exactly that, which is that the limited correlation between anatomic severity and functional impairment can potentially explain this discrepancy. So when we take patients who we measure the flow reserve using PET, and we evaluate their severity of angiographic stenosis using invasive angiography and quantify the CAD prognostic index, here you see it on a scale of 0 to 100, 100 being the most severe left main stenosis, and 0 being non-obstructive or less than 50% plaque. you can actually see there's quite a wide range of coronary flow reserve values, even in patients who have non-obstructive disease. So why does this matter? Well, we know that coronary microvascular dysfunction is prevalent. Here we see data from symptomatic patients who were referred for non-invasive evaluation with PET and had normal regional perfusion imaging. We found that coronary microvascular dysfunction was present in about 50% of them, had flow reserves less than 2. And this was true in both women and men. And a lower flow reserve was associated with worse prognosis in both women and men, even in those patients who actually had a calcium score of 0. This has now been shown as well for using invasive coronary evaluation. Typically, we find again that about 50% of patients who are referred with angina or signs of ischemia for invasive evaluation have non-obstructive disease, even using very exquisite diagnostic testing, including with fractional flow reserve. And then from those, the majority, over 3/4, have some evidence of coronary vasomotor dysfunction, with the predominant phenotype being coronary microvascular dysfunction. And so in patients with refractory angina, despite non-obstructive CAD, or potentially even following optimal revascularization, consider that coronary microvascular dysfunction may be the culprit. This is becoming relevant not just in angina presentations, but we're also seeing that patients who are being hospitalized for HFPEF, when we look, we find that, again, 50% have non-obstructive CAD, and a large majority of those have evidence of coronary microvascular dysfunction. And we and others have shown now that CMD modifies the effect of diastolic dysfunction on hospitalization for HFPEF. So here you can see that patients who had markers of diastolic dysfunction as well as an impaired coronary flow reserve less than 2 had a greater than 5-fold risk for a future HFPEF hospitalization. So whether a functional or an anatomic strategy is pursued first, we would posit that unexplained symptoms in your patients merit consideration for testing for coronary microvascular dysfunction. And this has now been incorporated into the 2019 European guidelines as either 2A or 2B recommendations. And to summarize, what is the role of coronary flow reserve, whether evaluated non-invasively with PET or potentially even invasively in diagnosis and prognosis? Well, we know that if the flow reserve is preserved above 2, then high-risk angiographic disease is unlikely and the prognosis is good. But if it's not, then independently of whether the patient actually has high-risk angiographic disease, their prognosis is substantially worse. And this obviously is important to recognize because it impacts upon the potential therapies. Obviously, in the presence of high-risk angiographic disease, guideline-directed medical therapies plus revascularization may be warranted, but which revascularization strategy may be best? And then similarly, in the patients who don't manifest obstructive CAD, what exactly is guideline-directed medical therapy for those with impaired coronary flow reserves? And this really highlights one of the emerging areas of need, because to date, there are no effective therapies that specifically target coronary microvascular dysfunction. But our tools such as PET have allowed much better non-invasive evaluation, which is allowing us to objectively define disease so that we can better plan and study the impact of flow reserve on management strategies using appropriate therapeutic trials. CoreMica did show recently that invasive coronary function testing, when linked to stratified medical therapy, did meet the primary endpoint of improving angina severity in patients with no obstructive disease. And this really brings into the possibility that, again, with really excellent diagnostic tools that we now have available, we have a much better chance of being able to help this growing patient population. So in summary, the focus on obstructive CAD is no longer adequate. We are recognizing this more and more, no matter where we look or how we look. And effective diagnostic testing needs to identify patients at high risk of events, not just anatomically obstructive CAD, but without overtesting those patients who are low risk. And diagnostic clarification of coronary microvascular dysfunction may help to avoid costly and unnecessary additional testing, which certainly can happen quite a bit, certainly in the US, and better define disease to develop evidence-based management. And then thirdly, PET, I hope you can now appreciate, is an important tool in our modern imaging toolbox for diagnosis and management of what I would say is our evolving understanding of ischemic heart disease. So with that, I'd like to thank you so much for your attention and to thank ASNC and TCT for the honor of participating with you today.
Sharmila, if you allow me one comment.
Yes, please go ahead.
Yeah, actually, any therapy, any modality becomes very popular with the clinicians as well as the cardiologists once you have a solution or a therapeutic choice to treat such problem. CMR, as you yourself mentioned, unless there is obstructive CAD which can be treated totally, it's quite challenging for us to, though we identify that is a cause, there is no definite solution or treatment which we can offer apart from medical management to this patient. That's where I think we are presently working towards, though you give statins and other measures of drugs which decrease the risk. But once something comes into Patrick's arrest or somebody's hands for some device or something, then it becomes very popular, especially in US and other areas. So we are, as we do not have any such things, that's how it is still in the mostly scientific data and diagnostic levels. But we clinicians want a solution. Suppose you come out with some molecule or some method where you improve this. That's where I think it comes into more and more practice. As clinicians, we want always best things to patients. Dil mange more types. We want more good things for patients. Hope we'll have an effective solution to modify total CMR in these scenarios. Thanks for your lecture.